we're being asked to now track what's going on and whether patients have stable housing and healthy food and transportation for medical appointments. And that's all good. The challenge with that is you're asking a health system, a hospital to address deeply entrenched and very expensive social issues, right? And this is where we have to look at the health of communities, and where people live, where people work, where people play has a huge influence on what their social determinants of health look like and whether they are able to really keep themselves healthy.
You're listening to the Public Health Insight Podcast, your go-to space for all things public health and global health, from the Sustainable Development Goals to the social determinants of health, as well as interesting dialogues about the diverse career opportunities that exist in these fields. Remember to subscribe to the podcast and leave us a rating on Apple Podcasts and Spotify so other people like you can benefit from our content. The journey to transforming healthcare is not just about technology or policies, it's about people. This guest story is one of resilience, ingenuity, and a commitment to change. From her roots as a first-generation Haitian American to her groundbreaking work at the intersection of public health and technology, she has spent over 15 years challenging the status quo. In this episode, we'll contend with very important questions, like is it a hospital's role to address the social determinants of health? What is a sick care system? Why are healthcare costs so high? And most importantly, let's talk about health equity. From PHI Media, I'm Gordon Thane, and I welcome a social change futurist, Sheila Phicil. Sheila, welcome to the Public Health Insight Podcast.
I'm really happy to be here with you, Gordon.
Absolutely. And like we talked about offline, there's a couple things I want to touch on. We're going to dig deep into your background, the decisions you made for your different degrees and your leadership roles. But before we get there, we want to get right into the juicy stuff from the outset. This term, health equity, it's something that's sort of simple to understand in your mind, but many people explain it differently. How would you explain it to a 5-year-old?
Oh, to a 5-year-old. Well, I would if I was explaining this to a 5-year-old, what I would say is health equity is making sure that people, no matter where they live, no matter what language they speak, no matter how old they are, no matter who they're related to or how much money they have, when they're sick, they can go to a doctor and get good care so that they can live a long and healthy life.
Okay, all right. That's pretty simple. Now, how would you explain it to your fellow public health professionals? Obviously, there's extra layers of complexity there.
Yes. I think it builds on that same concept of people being able to access good health care and access the resources that they need to stay healthy as well. Because we talk a lot about social determinants of health. So having healthy communities, healthy families, healthy homes, access to economic resources to take care of yourself, healthy food, all of those things contribute to health equity, right? And I think that when I talk about it in a professional world, I think often people are thinking of just a subset of people. Like I've worked, for example, very specifically in racial health equity because of what we've come to really understand about the disparities that are connected to race. But I think health equity beyond race also is just thinking about the overall infrastructure of healthcare and public health, and how does it work to make sure that all people, all families, and all communities have access to healthy homes, healthy communities, and access to the resources to keep themselves well.
Now, you mentioned healthcare a couple of times. So you're coming from the context of the United States, right?
Yes.
And you've talked a lot. You're many of those who are experts in the field that talk a lot about healthcare spending. And I believe we're up to 4.5 trillion a year in the United States. And so one might wonder, if we're spending so much money, why is there still differentials of outcomes? So there's a global problem here with too much money is being spent and there's inefficiencies. But within the way money is actually used, it actually widens disparities. Help us unpack sort of we're spending a lot, but we're not getting our bang for a buck. And then also, where's the money going when it does get spent?
Yeah, there's a couple parts to it. Part of the healthcare spending is coming from the fact that we have more of a sick care system
Sick.
where, yeah, so it's where people are typically accessing healthcare when it's very, very urgent or much too late, right? So they're often needing very high cost, very urgent care for things that could have been managed earlier or prevented altogether, right? Especially when we think about the high rates of chronic illnesses and other things, that's a big driver. So you end up having folks who are in a situation where they're going to the emergency room kind of as like the first line of defense rather than maintaining healthy lifestyles and doing preventive care. So that's a big part of it. And then the other part of that is what are all the things that we're spending money on to keep people healthy or to help them get better, right? And that's where I think we have a wildly disproportionate differences in terms of like quality of care that people are receiving, but then also how much we're spending on things. I come from the perspective of working in healthcare. So I've worked in hospitals most of my career. And I like to think of hospitals really as like pass through entities, right? Money goes into insurance
Mm-hmm.
from people and from government, it goes to the hospital, right?
Mm-hmm.
Doctors get some portion of that, medical assistants, nurses get some portion of that, the administrators like myself who are behind the scenes get
Mm-hmm.
some portion of that, but hospitals run on very thin margins. Most of the money on their balance sheet is actually going to pay the medical device company, the pharmaceutical company, the IT or healthcare platform that they're using. So, and on the other side of that balance sheet, you have companies that are worth billions of dollars that are not struggling to pay their bills at the end of the day, but you end up in a world where hospitals are closing. So that gets
Hospitals are
back to the
closing.
hospitals are closing.
Huh?
Yes.
That's a
Yes.
thing? That's such a foreign concept to me, like
No, that
from a
is
Canadian perspective.
hospitals are closing in the US. In Massachusetts, where I live, we had a whole health system go bankrupt and two hospitals closed. One of them
Wow.
was a hospital that was in a predominantly Black community. This
Okay,
has
there we
happened
go.
this year. Yes.
So
And it's
is
not
that
just
play
in
out
Massachusetts.
disproportionately for in communities?
It happens disproportionately in underserved, marginalized communities. So, rural communities, majority Black communities, poor communities are facing these issues. So, what does that end up doing is you have an issue with access, right? So,
Mhm.
when people are going to the hospital to see a primary care physician, you're having to wait 6 months to a year to even get an appointment. So, what does that mean for the person who found a lump in their breast, right? Or who is having dizziness or is extremely tired and losing weight if they're not able to access the health system to get the care that they need. I've talked to patients who have spent 24 to 48 hours in an emergency room before they were able to get a diagnosis, right? That's happening in America. That's happening today. It's happened to people that I know. So when we talk about health equity, this is an urgent issue and crisis right now in our communities right now, particularly in America.
My mind's blown. Like I'm struggling to articulate this next thought because so hospitals in this case are in need of more efficient use of funds in these communities. You're having these hospitals in communities maybe where they don't feel like they can make as much profit, or they don't actually make as much profit in those communities, so they get bankrupt, and then communities that are more affluent that can afford to pay those hospitals in those communities tend to survive. Is that the driver of hospitals going out of business in those communities?
That is one scenario that can definitely happen. Here in Massachusetts, it was actually a health system that was being managed by a venture capital firm. So this was a situation where lots and lots of mismanagement and value extraction was happening, not in a way that was maintaining sustainability for this health system, right? But you also have the other situation because I also have worked at an essential hospital. An essential hospital is essentially a hospital that takes care of people who are typically low income or have
Mm,
public health insurance. And those are usually Black and Brown people, right? Or folks that are struggling with substance use disorder, housing instability, and other things, right? So even there at that hospital, it was a constant challenge to be able to maintain sustainability, right? And to keep our budgets and finances afloat. So what ends up happening in a lot of those situations, we're pushing doctors to do more. We're asking doctors to see patients in 20 minutes
mm,
for illnesses that are like quite complex, right? And what has really happened over the course of many years of healthcare regulation, American healthcare system started as fee for service. So doctor did something, they got paid for it. That was got out of control and became a huge reason why healthcare costs so much in the US. So there was a lot of regulation that was essentially meant to disincentivize and regulate that behavior. And for the most part, it has been successful.
mhm,
But what we're not doing is we're not regulating the other expenses when it comes to healthcare, right? So we've asked doctors to transition to more managed care, for example, where they get a fixed amount of money to keep somebody healthy,
mhm,
right? And you have lots of, you know, rules around how doctors can bill and what they can bill for. We're squeezing more and more and more the activity of doctors and what they're prescribing or procedures that they're doing for patients. We're not looking at the overall
mm,
macroeconomics of healthcare because that same doctor is prescribing medications, is using an electronic medical record, is having to use devices that are made by a device manufacturer. And I've been an administrator. I've been in the role where it was my responsibility to go out and find companies to help us provide services to help us do the things that we need to do for our patients. And those things are very costly, and sometimes there's not a lot of options that are available. So it might be two or three companies that do this service, and you're having to pick between two or three high cost options, right? Because your
mm.
patients need that. So this is a broader conversation I'm hoping more people will have and have a deeper understanding of why healthcare costs so much in America in particular.
And it sounds like too the high costs you coupled with inefficiencies can put a strain on how a patient might experience that healthcare system because healthcare workers are overworked. Maybe you don't recruit the kind of the best ones, and then the patient experience suffers as a result of that before a system even goes like bankrupt and out of business. So it seems like there's a lot of different symptoms there for like a failing health system. So speaking, I want to come back to you talked about the macro view. So when I look at the macro view, I think about something that I learned about 80% of health outcomes being driven by social factors and not necessarily sort of at medical care or medical treatment perspective.
Mhm.
So can we talk about maybe inefficiencies in how dollars are allocated with respect to looking at the broader social determinants of health?
Yes. So I think we're just now in an era with new federal regulations where healthcare systems are kind of being asked to be a bit more responsible or accountable to social determinants of health, right? We're being asked to now track what's going on and whether patients have stable housing and healthy food and transportation for medical appointments. And that's all good. The challenge with that is you're asking a health system, a health, a hospital to address deeply entrenched and very expensive social issues, right? And this is where we have to look at the health of communities and where people live, where people work, where people play has a huge influence on what their social determinants of health look like and whether they are able to really keep themselves healthy. But that expense really falls on your local city and towns in terms of like what
Mhm,
services are available.
mhm,
What is the level of investment in public schools, for example, so that kids are getting good education, right?
mhm,
Or if necessary, like access to free lunch and other things that can sometimes be like a stopgap if there's housing or food insecurity, right? I benefited from public school breakfast and lunch as a very poor first generation Haitian American, that was often the only meal I had in a day, right? And sometimes we're relying a little bit on charity and organizations that are working to fill the gaps. But it's really hard, especially when you have higher rates of like cost of living and much more difficulty to access stable living wage jobs. So it creates a whole lot of stress for families to just take care of their basic needs. Now, is that really the responsibility of a hospital
Mm-hmm.
to fill that gap? I think hospitals can play a very important roles, and there are examples of hospitals that do. The hospital where I worked at, Boston Medical Center, had a rooftop garden and a food pantry on site. And it was offering a lots of services to kind of fill the gap. But what's really needed is a conversation around how are we empowering communities to care for themselves and what resources are going into that. And I think that's the conversation that's really missing.
So it sounds like in the health systems now, when patients see a healthcare provider, they're collecting that level of socio-demographic data. Then, so collection of data can be good if it presents a picture that can then be acted on. But what is do hospitals have a role in sort of where that data then goes to inform different decisions or policies or community interventions? Is that happening already?
That is, I think, would be ideal. And there are definitely hospitals that are trying to do that, collecting that information and then connecting patients with resources if they have it on site, but also those in the community. And then you have hospitals that are also looking at that information to inform advocacy and policy. The challenge with that, though, when you think practically about a patient who's showing up in an emergency room with a broken bone or just had a heart attack, and we're asking about, do you have a safe place to live? Do you have food at home? And trying to provide urgent care, or even in a primary care outpatient setting, you have a mom who has a sick baby and she has three other kids at home, and we're asking her questions about, are you safe at home? Like, how much can a hospital really do in terms of ensuring that home is safe and healthy and clean so that baby can stay safe and healthy and clean so that mom can go to work? That's still a huge burden and a big ask to ask hospitals to do that. And in most cases, hospitals are not being paid to provide that level of support. And you have a shortage of doctors already, a shortage of nurses already, and now we need extra support in terms of social workers and navigators and patient advocates. And where is the money going to come from to pay for those roles to provide that level of care? Because I've talked to patients, their expectation is that if you're going to ask me about whether I'm safe at home, what are you going to do about it?
There we go.
Patients are not going to answer those questions if they don't have the confidence that we can help them.
Right. And then healthcare providers are even more uncomfortable asking if they don't know what happens next based on collecting that information. What you said reminded me of one of my favorite quotes from Dr. Michael J. Marmot when he says, "Why treat people and send them back to the conditions that made them sick?" So
Yeah.
you described it sort of as a sick care system. And if your interventions are only at that juncture, you miss sort of where prevention can come in and divert some of the folks from a protective and risk factor perspective away from the healthcare system, preventing them from getting sick in the first place. You think about things that are environmental with the air pollution, asthma, and people having respiratory challenges. If those conditions are addressed, then they don't even need to go to the hospitals in the first place. So then what you shared about the macro being everything being connected. So hospitals get funded to do certain things. Other sectors should probably even be more funded to better address those different conditions that make up a holistic patient's health.
Yes. And you're exactly right. And by the time patients are engaging with healthcare, as we talked about before, usually it's a very late in terms of their symptoms, and it's much, much too late in terms of the social determinants of health. They've already been impacted by, exposure to chemicals in their neighborhood, right? That's leading to asthma, for example. Or they've already been impacted by the fact that there are not enough living wage jobs in their community. So they're juggling 2 and 3 jobs to stay afloat and not able to prioritize like healthy eating and exercise. Yeah.
Absolutely. Ready to switch gears?
Yes.
All right. So I didn't tell you about this one, but we have a little rapid fire segment that we like to do called Insight Blitz. And we essentially ask you questions or read some statements and ask you to provide a brief response to that. Ready for the challenge?
I'm ready.
All right. What is a skill that you learned early in your career that you still use today?
Early in my career, I learned to listen.
What is that? People
Yes.
say that, but what does that really mean? Oh, I'm a good listener. People will say it, but what do you mean by you're a good listener?
I'm not just listening for what people are saying. I'm listening for what they're not saying and for their underlying assumption behind what they're saying.
I'm going to steal that. Listen for what they're not saying. I like that. I like that.
Yes.
What's your ultimate guilty pleasure TV show or book or anything like that from an entertainment or education perspective that you like to indulge in?
That's a good question.
Podcasts,
I love
music.
books. I love books in general. I love audiobooks. I'm
Audiobook.
usually listening to a couple at the same time. But I don't know if it's a guilty pleasure, but because I'm usually like listening to a couple books, I like to get through them really fast because I'm impatient. I will usually listen to my audiobooks like 1.5 to 2 times speed. So, yeah, like, and now I can't listen, like even podcasts, I can't listen to them at regular speed. It sounds like they're talking and I can't. I have no patience.
It's hard to go. I will say I got that suggestion from a friend. I go at like 1.4. And then whenever I have to reset it, and I'm like, wait, this sounds really weird. Why is it so slow? And I'm like, oh, it's at 1 speed. So I definitely see what you mean by the 2x speed. That's okay.
Yes.
One word to describe your academic journey so far, which we'll get into. But
Purpose.
Okay, I'm not gonna. I'll save my follow-up questions for the next session. A career path that you might have considered if it wasn't in public health or healthcare?
Journalism.
Oh, what would you have covered in journalism? Sort of anything, or did you have a particular like area that you're interested in, or is that a skill set that you had?
I think human interest stories. Like I love like diving into stories in general and learning about like why things are and what was the journey that led to that. And as a youngin, I did radio and TV, so I probably should have been a journalist, but it just never crossed my mind as like a career. But yes, as I'm older now, I'm like, I love stories so much, like that probably could have been a career path for me.
Radio and TV? Tell me about that a little bit.
Yeah, so I was 8 when I started co-hosting a radio show.
Wow.
It was called The Voice of Children. It was on an AM station, primarily serving the Haitian community in Orlando where I grew up. That was kind of like my first foray into like, I don't know, like public service or community engagement. So it grew into a nonprofit organization called Children in Action. And my objective really was to empower other kids and encourage them to not wait until they grow up to be what they wanted to be. So I kind of like created this platform, and I'd have kids come on and they would share their stories or sing or dance. We did talent shows and conferences and all kinds of fun things. Yeah.
That sounded like fun. That sounds like that was fun. Speaking of experiences as a child all the way up until now, what's the worst piece of advice you've ever gotten?
Oh, you can't do that or you're moving too fast. I've heard that a lot. And I think it was coming from a place of concern or like genuine, like that's too much for you to handle. But I found that sometimes people have consistently underestimated my capacity to do things and to do more. And that has always been a challenge because it's like trying to honor and respect the fact that this person is maybe saying this from a place of like, hey, I don't want this to
Right.
hurt you.
Right.
But then I think it also comes from a place of like, this is my limit, therefore that's your limit. And I don't like it when people put their limits on.
Oh, if I was doing that, I don't know how I would cope. So I don't know how you're coping. Gotcha. Like it's for you to
Yeah.
decide essentially what your limit is.
Yes.
Gotcha.
Yes.
That's a good worse advice. That brings us to the end of our Insight Blitz segment. Wasn't too bad.
No, I wasn't. Didn't expect it, but it wasn't bad.
I didn't tell you for a reason. I wanted to get those spontaneous ideas.
This show was edited by me, Gordon Thane, with additional editing from LaShawn Benedict. Sound design and mixing by myself and LaShawn Benedict. The original music from The Music Room, composed by Tom Fox, licensed from Johnny Harris. The cover art designed for our show by LaShawn Benedict. The Public Health Insight Podcast is produced by PHI Media. Thank you for listening to the Public Health Insight Podcast, your go-to space for informative conversations, inspiring community action. If you enjoy our podcast, be sure to subscribe and leave us a rating on Apple Podcasts or Spotify. See you in the next one.